So first of all, thank you very much for the kind introduction, Dr. Hatem. Thank you for the kind invitation, also Dr. Al-Askar and Dr. Mansour Radwi. I really feel thrilled, and I hope that this is a nice transition between the previous talk by Dr. Ali and how to make a database, and to show you a real example of a database that we created, and also share with you the challenges that we faced in this database. At the same time, I also want to share my feeling of being proud Saudi. I'm very proud to be under a strong leadership by King Salman, Mohammed bin Salman. God bless them, because they show us the vision of how to basically improve. And I was really happy and proud in the first two lectures by Dr. Hani Al-Hashmi and Dr. Mansour, where they show us actually that Saudi Arabia is improving. And that's what we want to see in research. We're actually improving. The numbers are going up. Yes, we're not satisfied with the current situation, but at least we're moving forward. We're accelerating to higher ranks. And hopefully by Vision 2030, inshallah, we'll be one of the top 5, inshallah, countries in the world in research. As Dr. Mansour Radwi mentioned before, if you cannot measure something, you cannot improve it. And this is the value of basically data generation and database, because we want to measure things. In order for us to improve, we need to measure things. And this is the reason why we need to think about creating more databases and trying to collect more data. So I hope that I will share with you this journey of establishing a lymphoid database in our hospital, King Khalid University Hospital, and lymphoma also biobank. So before we start, why do we need the lymphoma database? I hope this journey that I'm sharing, it will reflect you in somehow, even if you're not interested in lymphoma, because I think you will see some of the challenges that we faced while establishing this database. But starting with the importance of this topic, you can see the Saudi Cancer Registry publication, the last one from 2018. We can see lymphoma actually is the 4th common cancer in Saudi nationals. So you can see that 923 were diagnosed in 1 year, which constitute about 6% of all cancers. This is one of the most common cancers in Saudi Arabia. When it comes to genders, we can see that in males, non-Hodgkin lymphoma is actually the 2nd most common cancer in men. And in women, it is the 5th most common cancer. So when it comes to a specific population, we can see that in patients who are young, 15 to 29 years old, Hodgkin lymphoma is actually the most common type of cancer in men. So you can see that we're dealing with a very, very important topic in our population. So despite these statistics, there is a scarcity of prospective data in lymphoma. I'm not really aware of any prospective database in Saudi Arabia. If anybody knows any prospective database for lymphoma, please let me know. As far as I know, there is no prospective data for lymphoma in our country. And also, even retrospective or observational data, there is very few studies that systematically evaluate lymphoma and lymphoproliferative disorders in Saudi Arabia. So roughly in our hospital, we diagnose roughly around 50 cases of lymphoma a year. Which is a sizable number of cases, and I'm sure in other bigger hospitals like National Guard and King Faisal Specialist Hospital, the numbers are much higher. It is expected in our hospital alone that in 10 years from now, we will be collecting more than 1,000 cases. I'm pretty sure it will be far more than 1,000, because so far we collected more than 500 cases. So I'm sure after 10 years from now, it will be more than that. So we will have a huge number of cases, which will generate a lot of research. So to achieve this goal of more than 1,000 patients, we need to have a comprehensive local lymphoid database that must be built to accommodate all the needed variables that we need clinically. And we acknowledge that a well-structured database with clear criteria is important. We need to have accurate information. We need to have few missing data. We need to focus on quality, auditing of the data, and maintenance of the data as well. And here I'm going to basically share with you a detailed description of how we successfully built this lymphoid database in our hospital. And I'm happy that now I'm telling the story because we started from the beginning of trying basically to plan for this database, to define what we want to do, gather the data, clean the data, describe, then analyze. And now I'm happy to share with you telling the story of this database. So we have faced a lot of challenges, starting with the question what. So we have faced a lot of what questions initially, as the first question was what disease area we want to focus on. We started looking at lymphoma. And so all cases of lymphoma are actually included, but we also just recently moved to also include plasma cell neoplasms. So you can think of it as a lymphoplasmacytic disorders. So we're including plasma cells now, and in the near future we will also add CLL. In terms of age, currently we started with adult patients, 18 years old or older, but we're happy in the future also to add more pediatric cases, inshallah. And we started collecting data from 2008 onward for logistical reasons. And we also had challenges on defining what variables we shall include in the database. As you know, there are many questions about what variables that we need to include. What is too much? What is too little? What are the variables that are essential? And I was happy to basically got a replica of the British Columbia Cancer Agency shared by Professor Joe Connors to help me start from a point where we can basically look at what variables are important for lymphoma. We are also glad to see that in our university, by the help of Professor Sultan, we established a REDCap service, which was really a big move towards anyone who's interested in building databases. And I can assure you that that one balloon that we saw actually in the reality and the real life, it's actually not one balloon. It's like hundreds of balloons that you need to face. We looked at initially at the objectives of the database, so primary objective and secondary objectives. Primarily, we wanted to look at prospective evaluation of outcomes of lymphoma patients treated in our hospital, and to provide a platform for translational or clinical research addressing lymphoid cancer. And secondarily, not to forget that we also need quality assurance, where basically having patients identification and tracking of patients with lymphoid cancer in our hospital, that will help us monitor the treatment outcomes. It will help us also inform the decision making in the hospital. For example, if you have an X drug that you want to approve for X or Y disease, you need to know how many patients are actually having that specific diagnosis to approve that specific drug in your hospital. So it is important to inform the decision makers in the hospital and the treatment policies. Quality improvement also is another thing to improve the patient's care, and also to also collect and supervise a lymphoma biobank, which we established along with this database. So currently we're collecting genetic samples for DNA and RNA, and we're also collecting a biobank for tissue, including immunohistochemistry analysis. One of the challenges that we faced initially was the ARB, with the specifically talking about the consent for biobank, because you know biobank consent are very specific, and we need to have Arabic forms and English form, and it took us a lot of time to basically develop an Arabic version of consents and to make sure that this actually fits with the biobank and policies of our hospital. Currently we have two basically types of data collection instruments, one for newly diagnosed lymphoma and one for relapsed lymphoma. And as I said, we have created recently a third one for plasma cell neoplasm in REDCap. I'm just going to show you some few examples of the variables that we're collecting. So we're collecting information on basically MRN, some of the residential national IDs, name, date of birth, and also age, which is a calculated field, and also gender. This is just a screenshot of so many diagnoses that we made in the diagnosis field, but it's just an example because there is a long list of other diagnoses. And we're also collecting information on clinical performance status by ECOG, the radiology type PET scan or gallium scan, and also the primary treatment. Again, this is just an example of a long list of medication or treatment protocols. We're also collecting variables on response. We're collecting variables on the secondary treatment, methods of transformation from low-grade lymphoma to higher-grade lymphoma, transplant, dates of last follow-up, and the fate of patients at last follow-up, and then also laboratory information like LDH, which is important, other laboratory, like CBC parameters, for example, and beta-2 microglobulin, stage, extranodal sites of lymphoma is also mentioned. In particular, these are higher risk extranodal sites like kidneys, adrenal, bone marrow, and also the largest diameter of the mass, the number of extranodal sites, stage group, which is limited versus advanced, the size of the largest mass as well. We're also collecting information on serology, like HIV, hepatitis B and C. We also have calculated field to calculate scores, which is a very important and really nice feature of REDCap, where when you enter the variables in the first, the previous, examples, it will calculate the scores automatically. So these are, the famous IPIs, for example, for lymphomas, CNS IPI, the regular IPI, FLIPI score, FLIPI, etc. So this is a calculated fields. Of course, calculated fields were one of the most difficult tasks to do in REDCap. I couldn't do it by myself without help of the people who were expert in REDCap. An example of this is age and also the prognostic scores, dates. These are calculated fields that were difficult to build in REDCap. We faced a lot of issues with also IT in terms of errors. Many times when you enter, I'm sure when you work with REDCap, you know how to deal with many errors and slow systems sometimes that you face. This was really difficult, and you have to basically deal with these issues all the time. Also, while collecting the data, the diagnosis was challenging because we collected the data from the Office of Cancer Saudi Registry. We were lucky to have an office in our hospital that is actually under the Saudi Cancer Registry, but physically located in our hospital. We were able to collect the MRN from them. However, most of the diagnoses were based on ICD, which is a very old kind of system. Nowadays, we're using the WHO, and there is several versions of WHO. So we decided to stick to WHO criteria according to the date where the diagnosis was made. So we did not basically rely on the ICD. And also finding the cases in our hospital, relatively it was easy to find them through this, the Office of Cancer Registry, because it's mandatory to report any cancer, as you know, in the hospitals. So now we found the cases, as I said. We defined the inclusion-exclusion criteria, and then we faced with a question of what's next, because it's not enough to just have all these planning. One of the biggest questions was who enters the data in REDCap. This was a difficult task. It was challenging. It took me a long time, actually, to figure out who will enter the data. because like as a clinicians, we were very busy. We cannot do this. I actually did not rely on medical students. I didn't feel comfortable to do that task. So it took me a long time to figure this out. And ultimately, alhamdulillah, we got a clinical research assistant who worked on this. But even clinical research assistant, actually, they needed a lot of training because many of them are not actually hematologists and they don't have enough experience in hematology. So I had to sit with them many times to basically make sure that the collection of data is accurate. And they have good experience with REDCap and other collection of data. REDCap also has nice feature of looking at the quality of data. So for example, there's this module that helps you to execute data quality rules to check for discrepancies in the data. So there is actually a list of rules embedded in REDCap that you can actually execute, and then it will tell you if there's any discrepancy in the data. This is an example of how you can make sure that the data are accurate and if there's any discrepancy. And what's nice about this also that you can also create your own rules. You can edit the existing rules as well. And then you can do this periodically to ensure the quality of the data. So far, alhamdulillah, we've collected more than 500, actually 516 cases. We also collected cases for biobank as well. And it is linked together, the biobank samples as well as the clinical information for cases. This is, I think, is a relatively a very good number to start with. And as the database becomes prospective, as I said, I'm expecting to have a larger number of cases. In terms of data usage, also another very nice feature of REDCap is that you can basically use these data to basically report it in plots. You can export the data to statistical programs such as SAS, Stata, SPSS, or R. You can also export it as Excel sheet. And you can also import the data. If you have data in Excel sheet, you can import it to REDCap. So there are different ways of importing, exporting data, which makes this very nice and useful feature. So far, we have made 3 publications. 2 of them were in PubMed, and more to come, inshallah. So I just wanted to share with you some of the publications that we did with the help of Dr. Musa Alzahrani, who was our previous fellow. This is just to show you from 10 years example from 2008 till 2018, the number of cases that we had in our hospital. Again, roughly between 20 to 50 cases per year. We can see that the 76% of patients were younger than 60, so younger population. And you can see that male versus female, about 59%, 41%. And also we can see that the stage advanced limited, majority of them were advanced stage. We can see the B symptoms present in 61% of cases. The pathological subtype, diffuse large B-cell lymphoma, was the most common, 41%, followed by classical Hodgkin lymphoma, which is 33%. This number actually here is double the number from the Western population. The Western population, about 15%, 10 to 15% of all lymphoma cases are Hodgkin. In our society, it's double. So that, again, Hodgkin lymphoma in our society is relatively common. This is a unique result. We can also see the outcome of patients there. If you take the overall survival for all patients group, looking at this graph, the Kaplan-Meier curve, these dotted curves represent the 95% confidence interval. But we can see that, alhamdulillah, the survival outcome is very nice. It's about 70% or so over many months, years. We can see that for age more than 60, we can see patients who are under 60 did better than older patients, which is expected. Again, for patients with high LDH, they did worse. and advanced stage, which is also expected, they did worse. These are just a few examples of the statistic and the survival analysis that we did. Looking at the diffuse large B-cell lymphoma, which is the common type of lymphoma, we can see that around 70%, which is a really good number, cured with Hodgkin lymphoma. This is more or less similar to the international data, which is very reassuring, alhamdulillah, that we're doing a good job of treating these cases and curing them. Again, for classical Hodgkin lymphoma, again, similar to the literature, above 80%, 85% or so of cases are cured. So we have collected all these from 2008 retrospectively up until May 2022, and now we're collecting this prospectively. And that is the plan, is to collect them prospectively and to have a prospective database. In the future, as I said, we're expanding to include plasma cell neoplasm, already added to the ARB. The data collection sheets formed, and the data collection is ongoing. In terms of the data access, which is important, so the data access currently is only accessible to our hematology group in our hospital. And in the ARB, actually, we made clear that using the data for external users can be done. However, there are specific ways to do that. This could be done for the purpose of conducting research or informing policy making, for example, for policymakers. And examples of external users could be internally from the KKUH, other than the hematology group, for clinicians, researchers, decision makers, etc. Or outside our hospital, could be other academic institutions like KMARC or any other institution is welcome to join. Healthcare regulators like Ministry of Health, regional, provincial, national, and international, hopefully, because of the biobank. I'm hoping that in the future we will have international research groups interested in this. So all information, in case of we need to release this to external users, all the information must be basically, when we're using the information outside, must be de-identified or remove the identifiers. This is a process of basically making the data anonymous and then reversing this anonymous by the data steward, which is mentioned in our ARB. The data steward has the key to reverse anonymization, and it is only done in our center. We cannot share it outside. And there was a talk recently about the national ID, and this is one way of basically hiding the national ID and maybe leaving the last 3 digits. And it is only reversed by the central authorized people in our database. So this is I think it's a nice way to link the data with other hospitals in case if we want to expand this nationally. And this is what I'm hoping, inshallah, yani, you guys will help me with, is to expand this database locally in Riyadh and maybe nationally in Saudi Arabia. I'm happy to work with anyone who is interested in doing this. Of course, we need funds and support, and inshallah, we will find that. Last slide, I would like to acknowledge all the people who have helped with establishing this. As I said, so the Professor Joseph Connors from British Columbia Cancer Agency helped me initially with starting a replica of the BC Cancer Agency variables. And then I would like to thank my groups, my colleagues, consultants for treating these patients. And also would like to thank our previous fellow, who's now a consultant, Dr. Musa Alzahrani, who helped initially with collecting some of the data before the clinical assistant. And then also Dr. Asfina, who made a huge part of collecting the data as a clinical research assistant. And recently also Maram Al-Harbi, who's taking this forward. I would like to thank Mr. Sheikh from the Saudi Cancer Registry Office for finding the cases. And last but not least, big thanks and acknowledgement to Professor Abdurrahman Sultan. This could not have been done without his support as a previous director for both ARB as well as the cancer, the research center in our hospital, and he helped a lot with this, as well as Dr. Reem Al Khalifa, who helped me a lot with the establishment of REDCap. And with this I conclude, and thank you very much, and hope that we'll get some questions about this.